In this presentation, Dr. Jennifer Scheme, professor at the School of Social Welfare and Goldman School of Public Policy at the University of California, Berkeley, highlights specific challenges faced by people in the justice system with mental illness and explores why these individuals are more likely to fail when incarcerated and on community supervision. When incarcerated, they have longer stays because they are more likely to have behavioral problems and therefore are not engaging in programs to earn credits, or are placed on administrative segregation, both resulting in reduced likeliness to be paroled. Once in community supervision, they also fail, having much higher rates of recidivism. Scheme investigates the implicit model we have of what works: sentence to treatment or a special program, both for the purpose of controlling psychiatric symptoms. Yet there are some problems with this, according to the research. Ultimately, Scheme goes on to emphasize the importance of taking a broader look at offenders who face mental health and substance use challenges in order to successfully provide treatment and reduce recidivism.
You will see a lot of figures thrown out about what the prevalence of mental illness is in the criminal justice system. The best ones still were done and offered by Linda Teplin in the 1990s. So I will walk through this relatively quickly. But she did comprehensive diagnostic interviews in the community. So she went out to find your neighbors, your friends, yourselves, and to do diagnostic interviews to figure out how often people met criteria for a major mental disorder. And I'm going to focus on the major mental disorders of major depression, which involves serious functional impairment. It's not just feeling blue. Bipolar disorder, which involves both episodes of major depression and also mania, where people can be very irritable, very active. They can stay up for long periods of time. They can be impulsive. And schizophrenia, which is what really comes to mind for many people when they think of serious mental illness. It's been called the cancer of mental illness because it affects cognition, emotion. This is where you most often see symptoms of psychosis, including delusions, fixed false beliefs, and hallucinations, which are typically auditory, people hearing voices that are not actually present. So Teplin, if we interview men in the community, and you think about yourselves, your neighbors, et cetera, and ask the basic question, how often will we find that men in the neighborhood suffer from one of those major mental disorders, you find that it is about 2%, which is that bar you can barely see there. All we need to do to find that figure triple is to do the same exercise in one of the largest jails in our nation, the Cook County Jail in Chicago, which is what she did. So you can see here that the prevalence of any one of those disorders is about 3 times higher for men in jail compared to men in the community. If we shift to women, we suffer from depression much more often than men for both biologic and social reasons. So the prevalence of those major mental disorders among the women in your community is more like 10%, 1 in 10. Again, if we go into Cook County Jail, we find that that figure doubles, where we have more like 20% of women suffering from a major mental disorder. So these are conservative figures. It's nice to have a round number to hang your hat on. And the best one, I think, was provided by Hank Stedman, Fred Osher, who used these data, bootstrapped the data, and basically said, it's about 20%. It's about 1 in 5 people who are involved in the criminal justice system who has a major mental disorder. That figure doesn't vary that much, whether you're in probation settings, say, or parole or prison. It looks like the figure is relatively constant. So it starts there, 1 in 5. And then we also have to recognize that these problems are really complicated because it's not just major mental illness, typically. When you take any one of these people who are in the justice system who has a major mental disorder, odds are more likely than not, they will also have a co-occurring substance abuse problem. So about 75% of the time, they will also have, typically, alcohol and drug problems. And then when we put that in the context of what we've become very aware of over the past couple of years especially, we see that problems really occur. So mass incarceration has gotten a lot of attention. The fact that we've had a dramatic rise in incarceration in the United States over decades now. But there's also American exceptionalism when it comes to community supervision. So we can also talk about mass community supervision and mass probation.
That's true.
The fact of the matter is that if you look at this graph from 1980 to 2006, the lines would keep going to 2012, and then there's a little bit of a plateau. But you can see that the correctional population has been exploding over time, and we already started with a fairly big one. So it's a very big system. It's processing a lot of people. It was not built for people who have serious mental illness. So one of the facts that we see that perhaps we shouldn't be surprised by is that if you take someone who has a major mental illness who's on probation or parole, so they're supervised in the community, their odds of failing supervision and returning to custody are 2 times higher than somebody who doesn't have a major mental illness. Shifting to institutions, in prisons or in jail, we see that people with serious mental illness are much more likely to be charged with infractions, to be placed in segregation, and to have a lot of problems, basically, while they are institutionalized. I will just point out here that a lot of our research focuses on probation and parole. The reason for that is because it captures about 70% of people who are on some kind of correctional supervision. The other reason we focus a lot on community supervision is because it represents really an unrealized opportunity for success. We have people in the community. We know that interventions are more successful typically in the community than in the institution, and yet we're still seeing that people are twice as likely to fail there. So this problem has attracted a lot of policy attention over the past, especially 10, 15 years. The problem was stated best by the Council of State Governments, who in 2002 noted that the current situation not only exacts a significant toll on the lives of people with mental illnesses, their families, and the community in general, it also threatens to overwhelm the criminal justice system. So one of the things that we've seen during the period that I've been studying this issue, which is quite a long time, is that a lot of the solutions to this problem have actually come from justice systems. It's less mental health people who are convening people, bringing them around the table. You see sheriffs, you see correctional institutions. So a lot of the solutions are coming from the system that can't say no. Probably everybody here, given that you're part of this commission or you're interested in the issue, is aware of what I've already told you, which is that people with mental illness are disproportionately represented in the criminal justice system. There aren't sufficient services in the community, specifically mental health services. This is very much in line with the most common perceived root of the problem. So, as the Council of State Governments put it, after they had done this very big consensus exercise with people who were on the front lines, they made this observation. People on the front lines every day believe too many people with mental illness become involved in the criminal justice system because the mental health system has somehow failed. So that's the cause. They believe that if many of the people with mental illness received the services they needed, they would not end up under arrest in jail or facing charges in court. You'll see this offered under a lot of labels. The most common label is the criminalization label. So what we have done is criminalized mental illness. After deinstitutionalization, when we emptied the state hospitals, we didn't provide sufficient funding for community mental health care centers, and now we are dealing with the consequences. So the idea here is that the justice system has become the de facto mental health care system, so that the largest, and this is true, the largest inpatient providers of mental health services in our nation are not hospitals, private, state. Instead, they are jails in our 3 largest cities, Los Angeles, New York, Chicago. So if this lack of mental health services is viewed as the root of the problem, then how do you solve it? You provide connection with services, right? It's very straightforward. This is a very straightforward problem with a very straightforward solution, right? So if the absence is services, then the key to fixing this problem is to provide those services. So what we've seen over the past 10 or 15 years is amazing creativity on the part of people in the justice system working together with people in the mental health system, in substance abuse sectors, et cetera. Lots and lots of creativity. We have now mental health courts, behavioral health courts, which are modeled on drug courts. We have specialty mental health probation and parole, where you're supervised with somebody who has an interest or background or training in those issues, and they have smaller caseloads. We have forensic assertive community treatment teams, which are built on a mental health service model, where you've got sort of Cadillac versions of services, including probation services, available to you. We have a whole assortment of jail diversion programs, including crisis intervention teams, where police are specially trained to respond to calls involving people with mental illness. The list goes on. So even though those programs that I just mentioned differ in their format, they differ in who is on the front lines, the judge, the probation officer, the team. They share a common model. And the common model this is an oversimplified version of what that looks like. So they all, or virtually all of them, use the justice incident, which is usually an arrest. They use that incident as an opportunity to mandate treatment. The idea then is that they get more psychiatric services more reliably, or maybe better psychiatric services, and that is the key to controlling their symptoms, and that will directly translate into reduced recidivism, right? So that will be sufficient to solve the justice involvement problem. We don't want new crimes, we don't want new victims, we want people not to be involved in the justice system. So that's the primary outcome that I'm focused on here when I say what works. There are other outcomes that are very, very critical for this group, including public health outcomes that we'll loop back to later, but that's not what I'm focused on here. Okay, so that's where we are with an implicit model. What I'm going to do in our time remaining is quickly talk about what we've found are problems with the implicit model. It's actually not that straightforward, as is sadly the case with most things in life. It's more complicated than a one-to-one relationship. So we'll talk about problems with the implicit model. We'll talk about how policy is now, even now, moving in a direction that will probably have better impact on recidivism and the outcomes that we've been focused on for this population. And I'll talk specifically about the most promising directions that we've been pursuing for trying to tune the model up, the policy model, so that we make more of a difference for more people. So, problems with the implicit model. The first thing I should say, by the way, is that I am a clinical psychologist. I was raised and trained to believe that we can heal all wounds, and I very much subscribed to the implicit model when I began research in this area too, that the problem is lack of mental health treatment and the solution is providing better mental health treatment. And I will say that one of the great things about research is it tells you when you're wrong. And we've learned that we don't quite have it right on a couple of fronts. So two problems that I'll highlight here. One is that we found that symptoms like delusions and hallucinations rarely lead directly to crime. And second, psychiatric services rarely reduce crime. Both of those things are important. So just briefly, there are lots of different ways that I could tell you that we found that symptoms rarely lead to violence and symptoms rarely lead to arrest. One of the easiest ways is to cover Carl Junginger's study. They had 132 people, most of whom had schizophrenia, all of whom had serious functional impairment. Of those 132 people, 4 had been booked that day as a function of serious mental illness. So the reason they were being booked was directly attributable to their symptoms. They also assessed whether the arrest was an indirect effect of serious mental illness. This might be, for example, that someone is feeling so depressed that they can't get out of bed and function, let alone go report to their probation officer, so they got picked up for a violation. So this would be an indirect relationship to serious mental illness. Another 4 there. So at the end of the day, what we have is, in this pool of people with very serious mental health problems, about 10% of their arrests, you can draw a line, directly or indirectly, to the symptoms that they were experiencing. But you are left with a lot of unexplained arrests as well. Remember, we said substance abuse was very, very common in this population. If we pay attention to substance abuse, we find that 1/5 of these people were drunk or high at the time that they were arrested, and another 8 or 7% maybe robbed somebody to help support a drug habit. So again, we have about 25% here. So what does this mean? It means that mental illness can and does cause directly some arrests, about 10%. And substance abuse is very much implicated about 25% of the time. And we still have a lot of the problem not explained. Now, it could be that even though symptoms rarely cause crime, stabilizing forces, having the right people, having structured time, it could be that psychiatric services help reduce crime anyway, even if we can't draw direct lines to symptoms. But really briefly, what we've learned is that psychiatric services are not necessarily the linchpin. If we don't work in these mental health centers, we spend a lot of time talking about the inadequacies of our mental health services, how hard they are to access, how they are provided by people with not the best training, et cetera. So skipping over that issue and instead going right for the gusto, right for evidence-based psychiatric treatment, that's really where we can look to see whether symptom reduction is going to translate into recidivism reduction. Assertive community treatment. So it is the Cadillac model of treatment for people who have serious mental illness. It's wraparound. It is 24/7. You have a team, psychiatrist, nurse, social worker available to you. It's assertive community treatment in the sense that they will roll out to your home and watch you take your medication. They don't wait for you to show up at the clinic, et cetera. So assertive community treatment is one of the oldest and one of the best validated evidence-based treatments. Evidence-based for what? Evidence-based for reducing repeated hospitalization, for stabilizing people who have recurrent symptoms and were cycling in and out of ERs and hospitals. So assertive community treatment. What Clark and their colleagues found in an experiment, the best kind of study, is that when you took people who had schizophrenia and co-occurring substance abuse disorders, and randomly some of them got treatment as usual, and some of them got assertive community treatment, they found that ACT worked as advertised. So people who got ACT were less likely to be hospitalized. They were functioning a little bit better. The problem was that didn't translate into any reduction in police contacts for this group. So whether they were in assertive community treatment or just treatment in the community as usual, 80% of them had at least one contact with the police over a follow-up period. There was no difference between the two groups in arrest rates either. It was about 40% for both groups. So that led these authors a long time ago to say it could be that if you want to achieve those different outcomes, you might need to think about different strategies. There is an adapted version of ACT called FACT, right? So they take ACT, which is the base evidence-based treatment, and they add typically a probation officer, so now it's forensic. And sometimes they view it as their job not just to help with the psychiatric issues, but also to reduce recidivism. The evidence on FACT teams is decidedly mixed. Sometimes it works, sometimes it doesn't. And the one thing that I want to point out is that even in the few studies where we've tried to get into the black box of treatment, we've tried to look inside these forensic programs like mental health courts or specialty probation and see if it does work, what is it about it that's working? We find that the answers are not the ones that we expect a lot of the time. So to give you just one example, we spent a long time, seven or 8 years, doing a big study that was a trial where we matched a group of probationers with serious mental illness who were in specialty mental health probation with a group who were on traditional probation as usual. So specialty mental health probation it fits the usual traditional implicit model. So there's a lot of emphasis on linkage with psychiatric services. People in specialty probation got a lot more psychiatric services. So what we did in the study is we basically followed these groups over time to see if specialty probation worked, and more importantly, why it worked. So the first thing we found is that specialty probationers, so again, those with an officer who had some background in mental health, who had reduced size caseloads, who acted as part of the psychiatric treatment team, the specialty probationers were less likely to be rearrested than those who were in traditional probation. This happened to be in Los Angeles, actually. So this is a pretty big effect. Those on specialty supervision were 2 times less likely to fail in the community, to be revoked. They were also about 2 times less likely to be rearrested, controlling for everything under the sun. So this is exciting. You don't see effect sizes this big in this business that often. What we found, though, is that it wasn't because of the logic model of specialty probation itself. So people in this really great program believed that the reason they were successful is because they were creating linkage with psychiatric services, that they had a lot of that emphasis. But what we found is we tracked people's symptoms over time. We measured it repeatedly to see whether people were getting better, they were getting worse, or they weren't changing at all. So that's basically a slope. What we found is that you could easily find people who improved a lot, right? So they have a slope of -3 or -4, and they're improving a lot, and they didn't get arrested. The problem is you can find people who were improving a lot and did get arrested. At the end of the day, you're basically finding that there's no difference in terms of symptom control. That doesn't translate into reduced arrest or reduced revocation. And it's not just our study. Hank Stedman has looked at this in his multi-site jail diversion studies, mental health court studies, and finds that, for example, filled prescriptions don't translate into reduced jail bookings. All right, so how do we do this better? One of the things that we need to start with is our assumption that we have one cause and one solution. So one of the things to consider is that people are whole people, that the mental illness is just one slice of who they are, where they come from, what they do. So it's important to consider alternative views. This is an example of one alternative view. It's Bill Fisher's view. It's not mine. I just offer it because it's a nice foil for where we started. So according to him, some people with serious mental illness may engage in offending and other forms of deviant behavior, not because they have a mental disorder, but because they are poor. Their poverty situates them socially and geographically and places them at risk of engaging in many of the same behaviors displayed by people without mental illness who are similarly situated. So the idea is that if you are in a place or have been raised in a context where problems are solved in a certain way, where there are liquor stores on every corner, where there are peers available for interaction that may not be the ones that your parents would like, that some of those same factors could be affecting people with mental illness in the same way that they affect people without mental illness. Now, I think it would be a mistake to drop one pat explanation in to replace another one, right? So we can't just say it's poverty, poverty's the cause. In the same way that we can't say it's mental illness is the cause. It's not that simple. It's just that this helps us to broaden our perspective, to consider other potential causes. And I won't go into a lot of detail on this, but we have a model that basically says, according to our theory, mental illness sometimes can and does directly cause criminal behavior. We think that's probably about 10, depending on the population, but it's roughly about 10% of the time mental illness is leading directly to criminal behavior. But typically, the stronger relationships are indirect relationships. So mental illness can put you at risk for drifting down the socioeconomic ladder. It can place you at risk for not establishing during adolescence some of those romantic relationships or career aspirations or other positive pro-social trajectories because you're dealing with first break psychosis. It can do a number of things that help set up the usual suspects. General risk factors for crime that apply whether you're mentally ill or not, even if the way that you happen to come by them was through mental illness. And the trick here is that when some of these get established, like criminal attitudes, it's hard to skip over these and actually make a difference when it comes to criminal behavior. So when we started seeing some of these early findings, we thought, that's funny. What could be going on? What could be the reason why we're seeing people with mental illness so often in criminal justice settings if we can't say it's the mental illness itself? So we did a study in South Central, actually, here. So we compared EOP and triple CMS parolees with a demographically matched sample of parolees without mental illness. And we're doing a really simple comparison of how big are their general risk factors for crime. So we used a risk assessment tool called the Level of Services Inventory. What we found in this study is that, to our surprise, the folks with mental illness not only had similar levels of general risk factors as their healthy counterparts, they actually had significantly more of those general risk factors than those without mental illness. What are these risk factors? What are we talking about? We're talking about things like having poor problem-solving skills, having problems with anger management, antisocial cognition, so criminal attitudes, believing that you're entitled to things. If someone leaves their purse out, they're asking for it. Having antisocial peers, you tend to engage in activities that are similar to those of your peers, so if you have antisocial peers, that's a risk factor for you as well. Family marital problems, school and work problems, substance abuse. So I've started here where the people with mental illness had more pronounced risk factors than those without mental illness. And you can see that they include some of the core risk factors for antisocial behavior, including criminal attitudes. And this has been replicated by 2 or 3 other investigators at this point. So that's the first thing, that we do find that these general risk factors apply to this population too. The second thing that we found in this study is that when we looked at what predicted recidivism better, these general risk factors or risk factors that are included on a different tool called the HCR20 that are unique to mental illness, things like, are they acutely mentally ill? Are they complying with their treatment program? What we found is that these general risk factors predicted their recidivism much more strongly to risk factors that we think of as unique to mental health problems. All right, so all of this is to say that we have this approach, especially in justice settings, I think, to put people in boxes or to assume that there are big chasms between, domestic violence offenders versus other offenders. And the basic point here is that we've had this approach that we have general offenders over here and people with mental illness over there, and they're completely different kettles of fish. And that's not actually the case when you consider that the strongest risk factors for recidivism are actually shared between the 2 groups. So if we want to refine the model of what works, remember this is where we started. So if we look back to that 2002 document and all of the things that were happening for a few years after that, the model that underpinned programs was you mandate treatment, you get psychiatric treatment, and that translates to reduced recidivism. We don't have to do a lot to tune this up. So The refined model, and one that the Council of State Governments is offering now that we're studying and validating and making sure that it does work, is we have here the same line. So nothing is different on the left side of the screen. So we have the treatment mandate, psychiatric services, reduce recidivism. What we've added is a second body of evidence-based treatment that we have, at least for this population, largely ignored until recently, and that is what works in general to reduce recidivism. So if we're interested in that outcome, then we're probably going to achieve it much more often through the correctional services route. All right, so this is new. What I'm going to do now is tell you 3 directions that we can say now are fairly evidence-based for folks who have mental health problems. So a few promising directions. The first is to target risk factors. This is the need principle, right? For the uninitiated, there's a model of correctional services that says that the most effective programs, the ones that reduce recidivism the best, are the ones who target services to higher risk cases, which we're not talking about here. The second principle is the need principle, which is they focus on criminogenic needs, which is a really sloppy way of saying risk factors for recidivism, right? So they focus on the things that are getting people in trouble that can be changed. And the bread and butter for doing that are these cognitive behavioral group treatment programs that focus on antisocial attitudes, antisocial peers, trying to create better problem-solving skills among people. This is such a bread and butter program that people have done meta-analyses, studies of studies indicating that this works, this works, this works. And you can fight all day long about brand name programs or generic programs, but anything that's implemented well seems to make a difference. So we have some signs that this is probably going to make a difference for people who have serious mental illness too. One example is Susan Young, who is in the UK, has adapted one of these programs that happens to be called Reasoning and Rehabilitation. She's adapted it to account for the fact that people with mental illness may sometimes have some cognitive problems. So it's kind of shortened, streamlined, built better for people with mental illness. And she's found in these forensic settings that it decreases criminal thinking, increases problem solving, and reduces disruptive behavior on the unit. So the issue about this is we don't know the effect on recidivism yet, and one of the reasons is because it is the UK and they rarely let people out of these forensic hospitals, so there hasn't been sufficient data to really know whether it works on recidivism. But we do have some promising data from here in the US, in Colorado actually. Stan Sachs did a study where this is prison-based again. So they had 3 groups, and this was an experiment. So they randomly assigned people in prison who had serious mental health problems to get stuff as usual, right? So you get your visits with your psychiatrist, the psychologist might see you occasionally. So that's mental health treatment as usual. But they also created a modified therapeutic community, which included group treatment that focused on criminal thinking and some of those other general risk factors that we saw earlier. And what they found is that after release, during the 1 year after release, those who had been in treatment as usual, psychiatric treatment as usual, a third of them came right back to prison. Half as many, right, so 16% who had also gotten the modified therapeutic community came back to prison. And for the few who also did some aftercare, so they went to a halfway house that continued that therapeutic community stuff, 5, right? So these are pretty big effects. All of this is to say that there's promise for explicitly targeting some antisocial features, even among people who have serious mental illness. Second, use core correctional practices. So remember the probation study that we talked about earlier that reduced arrest rates by 2 times, revocation by 2 times? So big effects weren't attributable to symptom control. What we found really explained the effect of that specialty mental health supervision program was the fact that officers, specialty officers, were much more likely to establish firm, fair, and caring relationships with those supervisees than were officers in the traditional setting who typically had much more traditional authoritarian type relationships with the officers. And I'm really glad that we listened to people before we started this study because they kept telling us it's the relationship stupid, it's the way that I'm treated, it's the way that things are done that makes a difference. And this just gives you some examples of the contrast between different relationship styles. I will say that this is not restricted to the probation officer-supervisee relationship. We've studied this in mental health courts. We've actually looked at it in the dual diagnosis court in Long Beach. We've studied it with treatment providers. So when a treatment provider works with somebody who is mandated to treatment, it's a dual role relationship, and some of these same issues apply there. So these are general principles that are important for working with justice-involved people. So we heard about one type of relationship, just a couple of quotes. The first time I met this particular probation officer, he let me know that he owns me. So this is an authoritarian, traditional, tail 'em, nail 'em, jail 'em type of relationship or approach. The first time I met him, he threatened to put me in prison. I got so damn scared, okay? And I didn't do anything. This is about a conversation between two. One officer's chuckling to the other one, nods his head toward me and says, "You can tell when he's lying because his lips are moving." So that was different from descriptions that we heard often in the same agencies of different types of relationships. So actually the first question he asks when I step into his office is, "How are you doing?" And he actually wants to know. For me, we all need encouragement sometimes to do the right thing. And it's okay with me as long as it's done in the right way. Talk to me, first of all. She talks to me the right way. So all of this is to say there's a lot of emphasis on how things are done, what the temperature of the relationship is, what the culture of the environment is. But we spent a long time and a whole study trying to figure out what's a good dual role relationship. How do we operationalize that? And we came up with a measure that does pretty well in showing whether and how people have been able to balance their cop role with their counselor role. And this is consistent with a lot of research, which basically shows that if you err on one side or the other, if you're even too therapeutic, you have a much shorter base of power for behavior change than if you effectively blend those roles to make a difference. Okay, so these are just some things we found about relationship quality, including the fact that it's important whether you have mental health problems or not. And that's something that we found in South Central LA, that even among high-risk parolees, high-quality dual-role relationships protect against recidivism there, controlling for everything else under the sun. The other good core correctional practice that was talked about, so in addition to how things are done, there's also what is done. And one of those is reducing reliance on punitive strategies. So the most common type of strategy in traditional settings is often the sanction threat, because it's fast, it's easy, it's time compressed. So punitive strategies would be like this: bark at him, chew him up one side and down the other, lie to him, say you're going to prison. People often view this as the big bluff because it's hard to find judges who will revoke just for treatment noncompliance alone, and when their bluff is called, they don't have a lot of authority left to offer. This is different than what we've seen in non-traditional settings, which is a core correctional practice called problem-solving strategies, where there's an emphasis on talking to the person to try to figure out what are the barriers to compliance, removing those, right? So maybe he's not taking his medication because he's having terrible side effects. So you help with adjusting the medication or talking with a psychiatrist. Once that's adjusted, then you agree on a compliance plan. All right, that's fixed. Here's how things will go in the future, and you've got everybody on board. So without going into the details, in addition to firm, fair, and caring relationships, some of these problem-solving strategies and reduced reliance on sanction threats were also what helped explain the effect of specialty mental health probation on recidivism. All right, so those are two promising directions that we know actually work with this mental health sample that are drawn from the correction side of evidence-based treatment rather than the psychiatric treatment side of the house. So why don't we just jettison all of it? Forget mental health courts, forget specialty mental health probation, forget anything special, period. And the reason for that is that there are very good reasons, even if you don't care about public health, to continue psychiatric services as part of the model. And because it needs to be continued as part of the model, we need to have people who know something about it involved in these programs. When we started this research, and we were seeing that whether it's the MacArthur Violence Risk Assessment Study, Junginger's study in a jail, our study of a completely new sample of offenders, we kept seeing over and over again that there's a small proportion of violence or crime that is directly related to symptoms. You can actually draw a line. You actually see that there's a relationship. So initially we thought that that meant that there's a small group of people among the people who have serious mental illness who reliably are involved in crime or violence because of their symptoms. So it's a group of people. And they're different from a group of people who reliably are involved in violence or crime for other reasons, substance use, general risk factors, et cetera. We were wrong. But what we've shown is that symptom-based crimes, the ones that you can draw direct lines between, occur almost randomly across people with mental illness. So as one example, we did a study, I think in Minnesota, where we found that if you took the 400 or so crimes that these 200 people had been involved in, about 2/3 of them were completely independent of their symptoms. About 20% were mostly independent, and then we had this rabble where there was a direct relationship. The problem was that there was no offender effect in there, so that didn't cluster by person at all. You would see these spread out all over the place. We found the same thing in the MacArthur Violence Risk Assessment Study, where only 10% of violence that occurred among people who had serious mental illness were actually preceded by delusions or hallucinations. And we didn't find a lot of clustering there either. So what does this mean? It means it is not the case that we have people with exclusively non-symptom-based violence and people with exclusively symptom-based violence, and we'd only attend to those in these special programs. Instead, what we have is most people with mental illness who almost never have a symptom-based crime or violent incident. But then we have another fifth or so of the population where it's just a mix of things. So you will find that they had some violent incident that was because they were hallucinating. But then you can find 3 others where that wasn't the case. It was for other reasons, general risk factors, et cetera. So it's not that we have 2 completely different species of people. Instead, we have mostly unrelated and then some peppering of symptom-based crimes for the other group. At the end of the day, what this means policy-wise is that these are unpredictable. You can't take a person who has had a symptom-based crime historically and say, aha, that's the one, right? And you can't take a person who's never had a symptom-based crime historically and say, it's fine. Symptoms have nothing to do with it. These are things that occur almost randomly. And what that means from a policy perspective is that we need to do prevention. So psychiatric treatment is important for public health reasons anyway. These are people who have serious mental health problems, so they should have psychiatric treatment in part because it is going to translate into some violence and crime reduction in a way that you don't know yet, right? Second reason to keep psychiatric services as part of the model is that it saves money. So we found in this study, comparing specialty mental health supervision with traditional supervision, that specialty supervision was cost effective. So this shows the costs per average probationer, and the red line here is traditional supervision, year 1, year 2, and then across the 2 years, versus specialty supervision. So you can see there's a lower cost across the board and that those differences are significant. So specialty probation costs less. Putting together all the mental health, all the criminal justice costs, it costs less than traditional supervision. At first, we thought that would be because of the reduced recidivism, right? But in fact, there aren't differences between the two groups there. What that means, in essence, is that what you're putting out in terms of having caseload sizes that are half the size of traditional supervision are more than offset by cost savings in terms of recidivism reduction. So it's cost neutral on the criminal justice side of things. When we shift to the treatment side of things and we're looking at treatment costs, we see that that significant difference is actually here. So what we're seeing is that people in specialty supervision got way more outpatient treatment than people in traditional supervision, but they also had way less emergency room visits and way less inpatient, expensive inpatient treatment than did people in the other group. So it's treatment savings. It's the psychiatric side of the equation that's really helping with costs here. All right, so we keep some specialty piece in the model. So we're in this place now where this is the most recent guide that's come out from the Council of State Governments, which does fantastic work and has been a really amazing advocate throughout this. So they just put out this guide that very much advocates thinking about both evidence-based correctional services for recidivism and evidence-based psychiatric treatment for some of the public health issues. And Hank Stedman and I found ourselves in this awkward position of actually writing a paper that said, wait a minute. And the wait a minute is really just about this. If we swap prioritization of evidence-based psychiatric services with prioritization of evidence-based correctional services without actually testing whether it makes a difference with this unique population, we will have not made much of an advance. So one of the things that we're advocating is, as I've sort of demonstrated here, making sure that things work, because this is a group that does have mental health problems. So the goal is to stop doing this, right? Putting the cart before the horse. And we're doing a lot of exciting initiatives now that try to avoid precisely that. Mm-hmm.
What would be maybe a suggestion that you would have as a council like ours to focus on as a target audience to address some of that stigma-driven decision-making that you mentioned in this slide?
Mm-hmm. So in terms of who to target for anti-stigma and how to do that, mm-hmm. the who to target have sort of been anybody who's making decisions, mm-hmm. right? So anybody who's making critical decisions about people should be targeted. I have a former student who's actually she's evaluating an anti-stigma program that really involves exposure, so bringing successful people with mental illness in to interact with, in her case, a group of probation officers, which seems to have more promise for loosening stigma, given what we know about attitudes and how they're not that responsive to someone coming in and saying, you're wrong about your estimates of how often people with mental illness are violent. That doesn't work. So the usual, I'm going to teach you out of your stigma, doesn't work as well as some of these contact with people and really understanding and knowing examples that fight the examples of what they get when they're supervising people, or that one case they remember. Mm-hmm.
Doctor, thank you very, very much. A very, very thoughtful presentation. I know we all appreciate it, so thank you.
Thank you.